Welcome back to Cancer Buzz TV, the show that delivers the latest trends and news in cancer care. I'm your host, Summer Johnson. Today, a multidisciplinary approach to anemia management in high-risk MDS and AML. Anemia can affect patients' quality of life and treatment outcomes, so it's an important condition for care teams to keep an eye on. Joining us today are Dr. David Sallman. He's assistant member in the Department of Malignant Hematology at Moffitt Cancer Center in Tampa, Florida. Dr. Amy DeZern, director of the MDS and Bone Marrow Failure Program, and a professor of oncology and medicine at the Johns Hopkins University School of Medicine in Baltimore, Maryland. And pharmacist Donald Moore, the Hematology-Oncology Clinical Pharmacy Manager at Atrium Health Levine Cancer Institute in Charlotte, North Carolina. Thank you all for joining me today. Dr. DeZern, we'll start with you. You specialize in MDS. Can you outline the pathophysiology of anemia in high-risk MDS?
Anemia is a presenting symptom in high-risk and low-risk MDS. The pathophysiology is a bit different in higher-risk myelodysplastic syndrome. Often, with higher-risk disease, we have the space-occupying lesion of the blasts, which are the MDS tumor population in the marrow taking up space, so there's less room for healthy erythropoiesis or red blood cell making.
Dr. Sallman, how does the prognosis of anemia and AML differ from that in high-risk MDS?
So I think part of the challenges for thinking about differential prognosis between MDS and AML patients is that really the prognostic systems have developed completely separate for each of those diseases individually. So although we do appreciate, especially based on molecular subsets, that there can be a very high degree of overlap between these diagnoses. This is probably most exemplified with TP53 mutant patients. As far as individual prognostication systems, they are really completely distinct. And why this matters is specific to the degree of anemia. So in MDS risk scoring systems, both the IPSS-R as well as the molecular IPSS, the degree or the severity of anemia do give weighted factors for a more adverse prognosis. So essentially, the worse your anemia, the worse your overall prognosis is, as well as the individual impact of transfusion dependence. As far as AML patients and AML prognostic models, really the presence of anemia has never been built into those prognostication systems. And thus really further work would need to be done to evaluate the relative impact. But again, for right now, the anemia plays a bigger role, again, in the prognostication of MDS patients. But I think this is an important question going forward, given the high degree of overlap that can occur between these diagnoses.
What factors influence the decision-making process when determining treatment for anemia and high-risk MDS and AML?
Yeah, so I think the first is really what are the goals of the patient? And so some of the really major goals is there a goal for curative intent for the patient? And really now for patients up to the age of 75 years of age, and now even pushing up to the 80 years of age, if the patient is fit and otherwise healthy without severe comorbidities, we can focus on cure. And meaning that for the vast majority of these patients, we're thinking about bridging them to an allogeneic stem cell transplantation. So in those cases, we really hyper-focus on what regimen is most efficacious in order to fulfill the wish of an optimal curative intent. But if that's not the goal of the patient, or that's clearly not an option, again, based on comorbidities, age, fitness factors, et cetera, then really our major focus is trying to improve the quality of a life of the patient. And a lot of this really does tie down to the severity of the anemia that patients have, and actually maybe often may support a more non-intensive regimen in order to get just as good of, let's say, a response, but maybe less harsh or toxic from how severe the blood counts can drop in the setting of therapy. So really, again, in the non-intensive or patients where we're not thinking about curative intent, thinking about therapies that can improve the hemoglobin or the anemia are really highly relevant. And when we think even about novel therapies, really only therapies that achieve some level of hematopoietic improvement or blood count improvement, particularly anemia, are the therapies that we are typically focusing on.
Dr. Moore, what's the impact of anemia on quality of life and treatment outcomes?
So anemia can often be a very primary driver in terms of reducing quality of life in patients with high-risk MDS. So there's often going to be a quite diminished quality of life in this patient population due to debilitating fatigue associated with the anemia, as well as the necessary treatments to alleviate the burden of anemia. So there's going to be frequent blood work, blood transfusions, physician office visits, as well as the potential need to travel to and from clinics or facilities in order to receive transfusion.
At the same time, are there major concerns about bleeding issues, infectious issues? And although we may not be able to get around those, again, can we personalize or choose alternative therapies based on the goals of the patient in order to mitigate some of those risks? Again, sometimes we will go with non-traditional higher risk therapies. Again, if the goal is really trying to solely improve their hemoglobin, improve their symptomatic fatigue, shortness of breath, even if that does not necessarily have disease modification capability. So it will really come down to what is bothering the patient, what are the goals of the patient. But yes, I mean, very much things will be personalized based on the quality of life issues that a patient is having.
Back to you, Dr. DeZern. What does a multidisciplinary guideline concordant care plan look like when working to optimize anemia management?
Anemia is such a key feature of how we treat higher risk MDS because we know that we must both give active myelosuppressive chemotherapy to treat the underlying high risk MDS, but we also have to support the hemoglobin so that the patient does not have symptoms from that anemia. The people involved in this treatment include pharmacists who help us prescribe the chemotherapy. Then we have nurses and advanced practice providers who assess our patients, both for their symptoms of anemia and certainly their quality of life while they're undergoing therapy. Then we need our blood bank clinicians who are often hematopathologists or pathologists who help us obtain access for blood to transfuse to the patient. And then the patient and their caregivers have to communicate their symptoms to us. So it really does take a village to manage the anemia of higher risk MDS.
Dr. Sallman, can you elaborate on the significance of the relationship and the collaborative care between your cancer center and the community blood bank?
Yeah, so no matter what, for really all patients with myelodysplastic syndrome and acute myeloid leukemia, particularly early on in their disease course and sometimes for forever, transfusion support is needed. I mean, this is needed both from a safety perspective of keeping patients alive, from a quality of life perspective, again decreasing these symptoms related to anemia or issues related to thrombocytopenia as well. So it really is a team-based effort. And in the community, I think one of the challenges versus, let's say, large academic centers is they don't have blood banks in their center. They can't necessarily transfuse right there immediately, upon seeing a blood check that requires a transfusion. So they really have to network either often with local hospitals, and again, how you try to do this on an outpatient basis, I think is a challenge. I do think there are ways to potentially further improve these collaborations because I think at times patients may wait a day, 2 days, even longer to get a transfusion, how many transfusions they can get, how are they monitored? And so I think we have some improvements that can be further done, but there's no question, especially as therapies are getting more complex and the side effects as far as the severity of cytopenias are increasing, this collaboration between blood bank centers and community oncologists is going to be increasingly important.
Dr. Moore, how do health disparities affect patients' access to care?
Yeah, so I think that in MDS, with a condition for which we would like to get patients to an allogeneic stem cell transplant, if possible, those with transfusion burden, health disparities can play a really important role in affecting outcomes. So referral to transplant centers for patients with MDS, that's going to be a critical point to be connected to a large center and to potentially receive much more definitive therapy. Also, payer and insurance status is going to be a major factor as well, as self-pay patients have been shown to have higher inpatient hospital mortality and poor outcomes relative to those with insurance. And a lot of that is multifactorial. It may be due to, patients without insurance having a higher tendency to delay seeking care due to the associated costs of seeking medical attention, and therefore they may present sicker. And also a lack of insurance can pose a barrier to access to care in general, as well as pose a barrier to be able to proceed to transplant.
Finally, Dr. DeZern, why is now an important time to be talking about all of this?
Currently, there's a great focus on anemia and MDS, and this is in part because the Red Cross has shortages of red blood cells at its greatest rate since the organization began. And we really, as providers, need to think through transfusion mitigation strategies, but also keep our patients safe. And so thinking through the anemia of MDS is particularly critical.
Thank you all for being here today. You can visit the show notes for more information on anemia management in high-risk MDS and AML. This show was made possible with support from Gilead. On behalf of all of us here at Cancer Buzz TV, thank you for watching. I'm Summer Johnson.